Today we will be conducting a head, ears, nose, mouth, and throat exam. At this point, the provider has confirmed the correct patient, introduced herself, and washed her hands, and obtained consent to touch the patient. We will start with inspection of the head. This includes the skin of the scalp, face, and head, noting any asymmetry, swelling, or discoloration. We will then palpate the head, feeling for any abnormalities. We will palpate the bones of the cranium, including the temporal, parietal, occipital, and frontal bones, and bones of the face, including zygomatic arch, orbital ridge, nasal bone, maxilla, mandible, and frontal bone. At this point, we will also palpate the sinuses, feeling for any inflammation or pain. This includes the ethmoid, maxillary, and frontal. We will then examine the ears. Starting with the external inspection of the ear, we will note any discharge, asymmetry, or unusual swelling or deformity. We will then palpate parts of the external ear, including the tragus, helix, and lobule. We will also palpate the mastoid process and note any tenderness with pressure. Next, we will assess hearing and cranial nerve 8 by performing the whisper test. We will ask the patient to cover the opposite ear that is being tested, stand 2 feet away, and whisper a word to the patient. We will ask the patient if they can repeat the word that was whispered. Their performance should be equal bilaterally. The Weber test is next. We will hold our tuning fork by the stem and strike it before placing it on top of the patient's head, and ask the patient to report whether they hear a sound louder in one ear or equal. Next, the Rene test will be performed, striking the tuning fork, holding it by the handle, and placing the stem of the tuning fork on the mastoid process. When the patient signals to the provider that the sound has stopped, the provider should quickly move the tuning fork to the external ear and ask if they can still hear the sound. The final part of the ear exam is visualization of the tympanic membrane using the otoscope. Hold the otoscope like a pencil and use the patient's head as a fulcrum. Pull the patient's auricle up and back. Insert the otoscope, noting any bleeding or discharge in the external auditory canal. Stop when you can visualize the tympanic membrane, which should be pearly gray and without holes or excessive redness. Also note the cone of light, manubrium, umbo, pars tensa, and pars flaccida. This will be performed bilaterally. We will now examine the nose. Inspect the external nose for bridge, asymmetry, lesions, discharge, and that it is midline. We will then palpate each side of the nose as well as the cartilaginous tip. Using a new tip, we can then use the otoscope to examine the internal nares. Tilt the head to 30 degrees, pull the tip of the nose upward, and insert the otoscope into the most inferior portion of the nose. Note the inferior and possible medial turbinates, and ensure they, as well as the septum, are bright pink and without polyps. Patency will be evaluated by asking the patient to occlude one nare, breathe in and out, and then repeat with the other side. The external mouth and throat will then be inspected. We will examine the lips for any lesions or dryness. We will ask the patient to smile, noting any missing teeth, gingivitis, or other obvious dental disease. Using a tongue depressor and a light, we will then ask the patient to open their mouth. We will examine the internal oral mucosa for any bleeding or abscess. We will note the location of Stetson's ducts at the second molar bilaterally. We will then ask the patient to stick out their tongue and say ah to ensure the uvula rises with phonation. While examining posteriorly, we will also examine the tonsils for exudates. We will then ask the patient to raise their tongue and note Wharton's ducts. The neck is the final portion of the exam. We will first inspect to ensure the trachea is midline from the front as well as each side, and that jugular vein distension is not present. We will then palpate the trachea for any excessive movement. We will also palpate the lymph nodes to assure they are not hard, immobile, or enlarged. This includes the preauricular, postauricular, occipital, submandibular, submental, anterior cervical, deep anterior cervical, posterior cervical, and supraclavicular. We can then palpate the thyroid from the front. When in position, ask the patient to swallow, and you will feel the thyroid rise between your fingers. Ensure the thyroid is soft, palpable, and moves with swallowing. Repeat from the back. Last, we will ensure the patient has normal range of motion at the neck. Ask them to demonstrate. Flexion by touching their chin to their chest, extension by looking towards the ceiling, lateral rotation by looking to the right and left, and lateral flexion by touching their ear to the right shoulder, then the left. Ask if the patient has any questions, thank them for their time, and wash your hands.